Good afternoon, everybody, and happy holidays as we approach Thanksgiving here this week. Welcome to November office hours. Wanted to thank you all for joining us this week. I know a lot of folks are probably getting ready to take time off, if not already starting to take time off. So thank you for joining us. Want to make sure folks can hear me all right. Uh, can you hear me out there?
Now I can hear you.
All right, thank you. You can see my screen all right?
Yeah.
Also, yep. Yes.
Perfect. And the chat function as well, hopefully.
Yes.
Perfect. So we're all on board. And as always, we're recording this session for future reference for folks if they'd like to utilize this for a resource. It'll be on our website in the near future. And as always, anybody has questions along the way or anything they'd like to talk about, feel free to use the chat function or stop us along the way. With that, we're going to start off with our agenda. We're going to have a presentation today, as I had sent out last Friday. We're going to have a presentation on the Chronic Disease Care Coordination Network by Katie Margison and Amy Kohansky today. So they'll be starting off for us as we get into today's agenda. And then we'll have our policy and procedure updates for our network, talk about some quality management performance compliance updates, children's updates, a little bit on the Healthy Alliance SCN, where we're at as a network for that. And then just touching base on special office hours that we're going to hold in early December due to some policy updates that the state has put forth that we have to address coming out of the gate in December. So that's what we'll have for this month's agenda. So we'll jump into our presentation. So I want to welcome Katie Margison and Amy Kohansky. So thank you too for joining us. So without further ado, I'll turn it over to Katie and Amy. We'll talk about the Chronic Disease Care Coordination Network.
Wonderful. Thanks, Travis. And for some of you, I'm looking at the participant list. This information you've probably heard several times over. So I do apologize for those of you who are well versed in all things Chronic Disease Care Coordination Network. I'm just going to take a few minutes today to level set with the group regarding a HRSA, federal HRSA grant that AHI received in September of last year. And that will transition into my colleague Amy Kohansky from the Heart Network in Saranac Lake, who is going to dive into more detail about the chronic disease self-management suite of programs so that you guys are equipped with the information that you need to recommend these programs to your clients if it's a good fit. So if you could go to the next slide, please. Great. So our overarching goal with this 4-year grant is to improve health outcomes. Sounds like a big goal. I get that. And that's kind of what we're all trying to do. But we want to improve health outcomes by looking at care coordination strategies that identify the needs of and individuals at risk for the development of heart disease and refer them to evidence-based chronic disease self-management programs and services, which Amy's going to talk about, as well as nutrition programs and supports such as SNAP Ed, Shine, fruit and veggie RX programs, and medically tailored meals, and tobacco cessation supports by way of either the New York Quits line, tobacco treatment specialists, etc., that are provided by community-based organizations. If you could go to the next slide. So a couple of basics on the grant. It is focused on 4 rural counties of Clinton, Essex, Franklin, and Hamilton. And I know that a lot of our health home presence is in the southern counties, but I also know we have a presence in the northern counties. And again, just trying to level set today, the information that Amy's going to talk about, I think, is really the important piece of today's presentation. Again, this is a 4-year grant, so we will be doing this work through August 31st of 2027 and hopefully longer. For those of you that have been around working with AHI for a while, our grant is really meant to be a continuation of the North Country Care Coordination Collaborative, or the NCCCC. Many of you probably remember Mary McLaughlin, who spearheaded the work under that grant. And this particular Chronic Disease Care Coordination Network grant is focused on continuing some of that work. We have several network members, some of which are on the call today, and that includes AHI Sisters Organization, the Adirondacks ACO, of course, the Heart Network in Saranac Lake, where Amy is located. Then we have the Northwinds Integrated Health Network, or IPA. We have Hudson Headwaters Health Network, and then 2 New York affiliates of UVM Health Network, including Alice Hyde Medical Center and Champlain Valley Physicians Hospital. Next slide. So to get into a little more detail of the programs that we are hoping care coordinators will identify eligible individuals and refer them to these programs include the chronic disease self-management programs, which Amy's going to talk about, really in the realm of like lifestyle health and wellness change and self-management. Of course, nutrition education and programs, that also includes registered dietitians and certified diabetic educators. I failed to mention that initially. And then of course, tobacco cessation. Some of the reasoning as to why we chose these specific programs and supports are that they are adjacent to the 1115 Medicaid waiver social care network work. And we're hoping to align our work and our processes and workflows with our pilot clinics to the work of the 1115 waiver. No sense in creating new referral processes or changes to existing workflows, but trying to align them as best as possible. And lifestyle change and some of the nutrition and all of tobacco cessation is not included in the 1115 waiver. So they are additional supports that we feel individuals who have chronic conditions or are at risk for chronic conditions could really benefit from. Next slide. I'm going to turn it over to Amy now to dive into what the chronic disease self-management programs are and how you can identify and make sure that your clients get access to or referred to these programs. So thank you. Amy, go ahead.
Thank you, Katie, and good afternoon, everybody. I appreciate the opportunity to share this information with you. The reason why we chose this of the 3 programs that we are increasing referrals into, hopefully, is because the chronic disease self-management programs, or as I will refer to them as the CDSMPs, are a little bit more nuanced as far as like figuring out who is the right fit for them and what exactly they are. So that's why we're diving into that today. And Travis, if I go too long, you please just, give me a nudge, tell me, okay, time's up, but I will try to keep it brief. So next slide, please. So first of all, these programs are evidence-based. That's really important for everybody to be aware of because eventually we are looking to hopefully have payers pay for them. So evidence-based program that was designed by Stanford University. It's important to know that. So I wanted just to state that. And next slide, please. So for those of you who like to dive into the research about the statistics on what the evidence has shown, there is a reference here at the bottom of the slide. You can dive a little deeper, but they have been proven to show that they reduce ER visits. They help people make positive changes in their life. And so that is what these programs have been proven to do, and that's why they're helpful. Next slide. So when we talk about the suite of programs, there are actually 5 different programs that fall under what we're calling the chronic disease self-management programs. The first one is chronic disease self-management, but then they get into some more specific conditions. So we have the diabetes self-management, chronic pain self-management, cancer surviving and thriving. And then kind of the oddball out of the whole group is the diabetes prevention program, which is out of all of them, it's the one that's not the Stanford University-based one, but it was actually created by the CDC and is heavily promoted by them. So it's a little bit different, but they're all considered CDSMPs. When we talk about CDSMPs, we are referring to this suite of programs. Next slide. So each one of the programs are facilitated by to leaders, and we call them peer leaders because they really don't have to be people that are in the health field. They don't have to be nurses or doctors. They don't have to be social workers or wellness coaches. They can be just individuals like the people who are taking the programs, the participants. A lot of times, a participant who goes through the program then decides that they want to become a leader themselves. They go through a training and then voila, they're a peer leader. There are peer leader trainings happening throughout the year. There's one starting in January. They are led by the St. Lawrence Health Initiative. And if anybody is interested or knows somebody who's interested, to either do it as part of your job for your organization or to volunteer, then those options are there. So please let us know if you're interested in becoming a peer leader. The CDSMPs, the first 4 of them that were on that list, are 2.5 hours long once a week for 6 weeks. And so right there, you might say, well, most of my clients are not going to be able to take that time. So one of the first things you have to think about when realizing is this client in front of me a good potential participant is, do they have the time? So you want to kind of like sift through and be like, the people who are working 3 jobs or going back to school and raising kids, those are not really the people that these are meant for. But think about that person who's maybe a little bit more isolated, or that elder couple, people who are retired, people that, don't have that much to do and are sitting in front of the television for 6 hours a day, people who are isolated in their lives, who can really benefit from a social, interactive type atmosphere. Those are the people you want to identify for these programs. And I realize that might only be 5 or 10% of the people you see. So this is a specific thing for those people. Another thing is important to realize that they're really helpful for people who want to make a change. And we might talk about that a little bit later, but that's an important piece also when you're identifying people who they're motivated. They want to make some changes in their life. The National Diabetes Prevention Program, that one is different, and that is a year-long program, and it's just for people with pre-diabetes. They will meet once a week for the first 6 months, and the second 6 months it will go down to either 2 or maybe even 1 time a month, just kind of as a way to wean them off the program. The NDPP currently is offered virtually, so anybody throughout the North Country can take that throughout the year. And it's really focused on weight loss. I mean, they will actually weigh you every week, or you weigh yourself and report in. And it's also really emphasizes physical activity. So the NDPP is different from the CDSMP. All right, next slide, please. So a lot of times I get the question, well, what kind of chronic conditions do you need to have to participate? And really, that's not the important thing here. You can have everything from maybe just a little bit of arthritis that bothers you once in a while to end-stage renal failure, basically. Anything in between. The type of condition really isn't as important. You can even be there as somebody who supports somebody with a chronic condition. And that's a lot of times why we have couples come in. One person has the chronic disease, the other person is their support person. So anybody can really benefit from these programs. It doesn't matter how sick you are. And then also, it's another great thing about these programs is they really help people develop a plan and set realistic goals for themselves. So small changes over time is the way that they are, the way that they work. Next slide, please. This is a list of the things that are covered throughout the 6 weeks. Now, I said that they are 2.5-hour programs. The way that they are set up is that they're going to go through maybe 3, 4, 5, 6 activities, which will take you through these different kinds of topics. So you're not sitting there listening to just one topic for 2.5 hours. There's breaks built into them. They skip around to different things to keep it interesting. It's also very interactive. people sometimes sign up thinking that they're just going to sit there as if they're in front of a webinar like you guys are now, camera off, it doesn't really matter. But that's not the way the CDSMPs work. They work by, you have to have your camera on if it's virtual, you have to participate, everybody's talking and sharing in the group. So it's also for people who want that kind of a support and environment. They talk about goal setting, decision making. The action plans are where people become very accountable for their actions. They have to report back in the following week how they did on their action. They deal with symptoms like maybe shortness of breath or balancing issues that can often accompany chronic conditions. There's alternative techniques to managing pain, like distraction techniques. Of course, healthy eating and physical activity is interspersed throughout the 6 weeks. Interpersonal relationships is interesting. They talk about, how to become a better communicator with your partner, with your friends, with your primary care provider, etc. And then another big piece is the stress management. There's different types of relaxation and breathing techniques that can help people deal with the stress of having a chronic condition. So as you can see here, there is a lot that is covered. And next slide, please. So another question I hear a lot is, well, where do they hold these? Where are they happening? And the answer is they're happening all over the North Country. They happen in community-based organization sites like YMCAs, libraries, adult centers. Those are all different hosting sites, and they're even sometimes held at hospitals and clinical sites as well. The delivery organization, if you hear that word, that is the organization that holds the licenses to run these programs, but they don't always do them on site. So Office for the Aging, for instance, may be a delivery organization, but they host their program at a community site outside of their organization. The delivery modalities, this is important too, because these are the kinds of questions you need to ask your clients as you're trying to decide whether it's a good fit for them. First of all, is it in person? Do they have transportation if it's in person? If it's a virtual, do they have Wi-Fi? Do they have the technology? Do they have a laptop or computer with a camera? And if they don't have either of those things, they also occasionally, not as often, but they offer these programs as what they call a telephonic, which means it's basically just a phone call. And they, in those situations, they limit the number of people to about 3, and they shrink it down to about an hour instead of 2.5 hours. But it's still available to people who don't have transportation and don't have the technology, if you can find one in the telephonic version. And I just mentioned here that the NDPP are only offered at Claxton Hepburn at this time. So we are looking for other organizations to maybe take that on. If you happen to be an organization that would like to provide those, you could reach out to me. All right, next slide, please. We're getting there. So as far as referral and how to get people connected with them, we are working with Healthy Alliance to get the CDSMPs set up in a user-friendly way in Unitas. So because that is what the 1115 is using, we want to align with that. So that will be the main platform at this current time, the best way, and it may remain the best way. There's no reason not to. Just actually sign them up yourself. I'm going to show you how the website and what it looks like to sign somebody up. People can also sign themselves up. And we have RAT cards with the website on it that you can just easily hand to a client if they're not quite ready. And then maybe they'll sign up themselves at some point. So those are options. And next slide, please. So again, this is just, I think it's a repeat of what I said. Providers or yourselves can sign people up, or they can sign themselves up. All right, so, and the Get Healthy NOCO, Get Healthy North Country is what will take you to this site here. So this is what you see when you get to gethealthynoco.org. And if you don't find a program that will work for your client at that time, you can put you can request information there. And next slide, if you scroll down, you'll see the list of programs. So this is actually from last year. It's not what's happening right now, but this is a screenshot from all the programs. So it says, first it has the program, and then it has the delivery site. So you see there's telephonic or in person or hybrid or live, online. Those are the ways that it's being delivered. And if you want to register, you just click on the green button that says register, and that takes you to the next slide, please. And this is where you could put in your client's name and information. This is, I highly recommend doing it with the client while you're with them, if they're interested, of course. And that way you know that it's going to happen, and somebody will reach out to them and contact them, and etc. But there's one thing here I wanted to bring to your attention. If you are filling it out for somebody, where it says, how did you hear about this program? That's going to, if you click on that, you would get a drop-down screen, and we would request that if it was a care coordinator or a care manager or care navigator, whatever you may call yourself, that you would hit the one that says healthcare provider. We don't actually have in that list care coordinator, so healthcare provider will give us the information we need, and it'll give the Heart Network the information they need. That they're collecting. So that's how easy it is to sign somebody up, or a person can sign themselves up again at gethealthynoco.org. And next slide, please. I think I'll just draw your attention to the last three here. You might want to consider if a person is a good candidate here. Ask the time commitment, ask if they have the technology or the transportation. So those are the three T's: technology, time, and transportation. Those are the three things to ask. And then if they aren't interested in signing up, then the RAC card. All right, next slide, please. And I think we're going to actually skip this slide here, go on to the next. This is the front of the RAC card, and if you don't have them and you would like some, please reach out. I would be happy to deliver and or mail some to you. And the back is on the next slide. And if you look at the bottom there, it does have the website, gethealthynoco.org. And so that is how we are directing people to sign up for these programs. Next slide. All right, so I said to reach out to me if you want to information on becoming a peer leader, if you need RAC cards, or if you still have questions about these programs. The way that we get them out to you all is when there is a new program happening, I generally send them a flyer out to office managers and you know, different places like that. I don't send them to each and every one of you individuals. So I send them out to a group of people who then can send them out to you, is the way I kind of see it, although I can't see exactly who, everybody who's on this call. But if you see one coming through, a flyer come through on your on an email, then please check it out and see, maybe print a couple out and show them to the clients, because usually when we send them out, there's like, I don't know, like 6 weeks maybe, in order that we're trying to fill that class. And so that would be the time to really stress if you have people in that particular area. Right now, we have one starting January 8th. It's an in-person in Potsdam. We have 2 virtual starting in January, a CDSMP and an NDPP starting in January. Those are 2 virtual options. Or if you're in the Potsdam area at all, then that would be in-person starting January 8th. So again, the cadence of these changes all of the time. You might have a lot happening at one time, and then you might have a little lull, like December starts are, we'd call that a lull, but we have some starting in January. So we'd be looking to you folks to talk to your patients about it, your clients. And so I think that wraps it up for me, and I'd be happy to take any questions if you have any.
Thank you, Amy and Katie. That was very, very informative. Is there any questions from anyone for Katie and Amy?
Well, I thank you very much. My contact information is there. Please reach out if you come up with any. All right, have a great day.
Thank you both. Really appreciate your time today. Have a great Thanksgiving. And you're welcome to stay on if you'd like to hear about Health Home. If not, you got the recording. Thanks again.
All right, thanks. Happy Thanksgiving to you too.
Happy Thanksgiving. All right. We'll move on. Jessica, policy and procedure.
All right. Policy. It's saying I'm muted. Can everyone hear me?
Oh, we can hear you. I can hear
Okay,
you.
perfect. I
can hear you.
tested this and then it was telling me I was muted. Okay, so policy and procedure that we're going to review today is going to be the Children's HCBS waiver disenrollment and discharge policy, plan and cares for adults, system access and identity assurance, disenrollment and HCBS rights and choice. Some upcoming policies that we're going to have are going to be the CANS, New York policy, notice of determination and fair hearing, CS transfer policy, billing protocols for newly referred members from an excluded setting, consent and a transfer policy. Those are just some of the upcoming policies that we have forthcoming that will be reviewed in a special office hours in December or in the January office hours. And go to the next slide. All right. Children's waiver, disenrollment policy, and discharge policy. So just to review that anybody who is enrolled in the Children's HCBS waiver, it is a voluntary program, so you do not have to be in the program. So when we have somebody who would elect to disenroll or they disenroll for other reasons, the first thing we want to know is understand why the person is disenrolling from the HCBS waiver. And if they're disenrolling from Health Home or Health Home and HCBS, and keep in mind if they have a KK code, because that means that they're family of one, which means that if they choose to disenroll from HCBS, they actually have to disenroll from HCBS and from Health Home. Our other kiddos that do not have a KK code, they can continue to stay in Health Home even if they came from CS. So if we got a referral from CS and they came over to us, that does not always necessarily mean that they're family of one. So you always want to check e-paces. If you're unsure, please always reach out to me and we can figure out a plan for that kiddo to ensure that they remain in the correct set of services and continue to stay enrolled in the Health Home program if they wish. So if they are going to be disenrolling from HCBS and from Health Home, you want to make sure that you're also following the Health Home disenrollment policy as well as this policy. There's going to be two sets of policy that you have to follow if you're going to disenroll a waiver kiddo from Health Home and from waiver. We'll go to the next slide. All right, so if we are going to disenroll a kiddo from HCBS from the date of decision, you have to notify the family on that 5288. So within 1 to 2 business days of the family requesting a disenrollment, from 1 to 2 days of getting an ineligible level of care, you have to then notify the family on that 5288, and you also want to notify the Health Home. It's extremely important that I'm aware of those kiddos that we have that are going to be disenrolling from waiver, so I can monitor that the disenrollment was followed. And then I also, number 4 here, I need to check the documentation and then I will notify the Department of Health that that member has disenrolled. So we're no longer utilizing the process where the care manager directly reaches out to DOH through capacity management. You guys are no longer doing that. You will reach out to me and I will have the K code removed, or you're going to use one of those end reasons in NetSmart. So regardless of the reason that that member is disenrolling, you will either use disenrolled from HCBS or disenrolled from HCBS and Health Home, and that will kind of indicate if the K code stays up or if the K code comes down. Again, if you're unsure, you always want to reach out to me to ensure that we are keeping those K codes accurate. There is going to be a new feature in our notice of decision policy that K codes are only active for 365 days. So after 365 days, they will automatically end. So it's going to be extremely important that we are taking down K codes when appropriate and they are staying on when appropriate. So we really want to make sure that we're using the correct end reason, or you are reaching out to me so I can notify DOH. The next things we want to do is make sure all of our documentation is uploaded into NetSmart, and you need to go into IRAMS and remove those HCBS referrals that you have put in IRAMS to close out the record. And then that would also let the HCBS provider know to take that member off of their list. And go to the next slide. Travis, there's like a huge delay in the slides advancing.
Yeah, once you're saying it, I'm advancing.
Okay.
So yeah,
I didn't know if it was me or.
it's a delay.
Okay. Does anybody have any questions on HCBS disenrollment? All right. Let me pull up my set of slides.
Is it advanced yet?
No, it's still like frozen on that slide deck.
It advanced on mine. I can see the
It
advancement.
is. On mine, it's frozen.
It's
See?
frozen on mine too.
Even the computer is telling you no more policy changes.
Lori,
Yeah,
just
this one is
stop right there.
This one's showing
because-
the plan of care.
So
Okay,
it's-
You
thank
knew I wasn't gonna let that go.
Does it say a big stop sign, Lori? STOP.
All right, I'm gonna keep talking because for some it's frozen and for some it's not. We'll send out the deck afterwards. And to Lori's point, there's a lot of policy change, and I wish I could tell you guys that it's slowing down, but it's absolutely not. Hence in December, while we're having that special office hours, just because we have so much change, we can't skip December's office hours, so we are going to host a special one, and Travis will comment on that later. But I'm going to move in to the next plan of care for adults. So I just want to be mindful and remind everybody, oh, there it goes. Then an initial plan of care for adults and for children, even though we're talking about just adults here, that does have to be done within 56 days of enrollment and then every 365 days. So you want to make sure that you're staying on top of getting those plans of care done, because that will allow you to bill any overdue plan of care, any service that you deliver during that time period that the plan of care is overdue, you cannot bill for. So you want to be mindful of that. You always want to make sure that the plans of care are reflecting the member's needs and supports the member's enrollment into health home. So whatever makes them eligible for health home, whatever makes them appropriate for health home, that those things are being addressed in the plan of care. We always want to make sure that our plans of care are signed by our enrolled members, and that the needs from our comprehensive assessments are addressed in our plan of cares. I will let you know that one of the major pieces of feedback that we got in our redesignation exit survey was that the needs from the comprehensive assessment were not carried over into our plan of care. They found that our comprehensive assessments really lacked information and lacked the need for health home and the comp, and then that lacked then carrying over into the plan of care. So that is something that we will continue to improve on and to view when we audit. So just really to keep that in mind moving forward. Does anybody have any questions on the adult plan of care policy? All right, Taylor, are you going to do system access?
Yes, can you guys hear me?
Yes.
Okay, perfect. Okay, not much to say on the systems access and identity assurance policy. There were no changes, but we did do our annual update. I just wanted to throw on the slide as a reminder for everybody to send in those forms for deactivation when you have users or staff leaving your agency. That way we can make sure that all of our systems are up to date and we're removing access appropriately. Usually at least once a year, I will send out a list to each CMA of the active users that I have on file just to kind of reconcile those lists. So I will probably do that sometime during Q1 of 2025.
All right, does anybody have any questions? All right, moving on to health home disenrollment policy. So a member, again, we're a voluntary program except for those folks that are on AOT. So members are disenrolling for various reasons, member choice, they're being disenrolled to the CES tool, they're being disenrolled because they're pended, and their time runs out. So they've been in diligent search for over 3 months, pended for incarceration over 6 months. So we have lots of reasons that people are disenrolling out of health home. We always want to make sure that we are making a discharge plan and documenting that discharge plan in the member's record, and that we're selecting the correct end reason that we're closing that member out for. You always want to make sure that that member is being issued a letter, their disenrollment letter, and that it is documented in the record. So they're going to receive a discharge plan, their letter on agency letterhead. That's all documented in the record, and that we're notifying the care team that you have been working with that member has been discharged. The other thing is that if a member, you can go to the next slide, Travis. If a member is being disenrolled to the CES tool, we are not transferring that member to another CMA. We will make the determination at the time if that member should be re-enrolled due to eligibility and appropriateness. There's appropriateness is spelled wrong and no one caught it. If we feel, so if you have someone that you discharge and then that member comes back to you, they meet eligibility and appropriateness, potentially they could be re-enrolled. If it comes to the health home, we are checking every referral to see if it has been discharged within the last 90 days. If it's over 90 days and the referral source thought it was appropriate, we will get those people out to you. If it's been under 90 days, we are having an internal discussion if that member is truly eligible and appropriate for health home. If a member is ever in disagreement with their discharge, or you cannot have a documented conversation with that member. So let's say that they're pended, diligent search pended, then they fall off diligent search. You do not have a documented conversation with them, or you're disenrolling them, let's say due to the CES tool, they're not in agreement with that disenrollment. They do have to be issued that 5235. That will give them a right to the fair hearing. We will touch on notice of decision and fair hearing further in our December special office hours, but you always want to make sure that you're doing the letter and the 5235, or if the letter is just sufficient. And I have added a desk guide to this disenrollment policy to kind of help the care manager ascertain whether they need the letter and the 5235 or just the letter. Does anybody have any questions on disenrollment?
So this is Sarah. I just had a question.
Sure.
So we're saying that the time frame is about 90 days. Is that so? If we do the CES and they need to be discharged and we discharge them, are you saying that if you get another referral after a 90-day period to re-enroll them, that they can be re-enrolled?
So Sarah, there is no hard and fast rule on when a person can come back to health home after a CES tool disenrollment. If we have a re-referral, so say, SLPC discharges someone, you felt that they got the CES tool, recommended discharge, you work with them, they get discharged. And then 60 days later, we get a re-referral for that member. We're going to look at that record from the health home level and see if that person is truly eligible. They just graduated. Are they really eligible to come back? Was something happened during that 60 days that would truly make them eligible and appropriate? It was just kind of an arbitrary timeline. So we picked 90 days that any referral that we get we get through the health home that has been re-referred under 90 days from disenrollment, that we will really look into that referral over 90 days, just because we don't have the capacity to kind of research everything. We know, okay, if it's been 91 days, we'll probably go back to you, Sarah, and say, hey, this person was re-referred again. Would you like to pick them up? It's then on, as always, it's always on the CMA and the care manager to make sure that that member is eligible and appropriate for health home. That hasn't changed, and that process hasn't changed. We just needed a way to kind of make sure that people were not disenrolling from the CES tool and then immediately being re-referred back, or they are being transferred. So we're seeing it one of two ways happening, and it's kind of a way for us to catch that from happening. So whatever your workflow is currently, it's currently fine. Otherwise, you would have heard from one of us. So I wouldn't be too concerned. Does that answer your question?
It's just probably one of those examples where it's, something DOH is doing that's a little bit confusing. If we're having to do all the assess and we're having to disenroll people, even if we might disagree with it, just to not have like a standard set date, or for them to be able to just come back on in a few months. There's a little bit of probably frustration there, because I think there are cases when we're saying, yeah, we see why this is happening, but we still see how this person would benefit from staying, but we're not given the option. And there's just no clear guidance from DOH on a time frame.
Yeah, and so a lot of times when we do get guidance from DOH, it's usually clear as mud, and they usually will not directly answer anything because they want it to be left up to the health home to kind of dictate how they want that policy done. And then if they don't like how it's going, all of a sudden that's when we will see a policy change where we do see a time frame attached. I can tell you that there are other health homes out there that do not do any sort of check. If a person is discharged and then re-referred the very next day, the health home is not doing anything to check to make sure that that person that has been discharged is truly eligible and appropriate coming back. It's just a risk that we weren't willing to take, especially just going through redesignation, and they are looking at re-enrollment rates. It's just a way for us to kind of ensure that we're really serving people who are truly eligible and appropriate. But I also entrust in all of your professional judgments. So if you are disenrolling with somebody who you don't feel should be disenrolled because of the CES tool, always keep in mind that they have a right to a fair hearing, and they can always check off aid to continue. So that is another option that we do have for these members that we also are in disagreement with their disenrollment. So you can continue to serve them that way, but also if they're coming back to us, we will usually, if we're struggling to make a decision, we'll reach back out to the care manager, the supervisor that previously served them. So I'd be like, oh, Sarah, we got to re-refer for this member. And you would be like, oh, dang, I knew that was going to happen as soon as we discharged them. Yes, send them back to us. It just allows us to have the opportunity to have that conversation with the care manager and the supervisor.
Okay, sounds good. Thank you.
Yeah. Sarah, one of the things when we just went through our redesignation, to Jessica's comment, we were questioned on how we were checking and assessing those folks who were discharged through the CES tool. What were we doing as a lead health home to monitor that process? So we were asked that right out of the gate when they were looking at our quality and compliance process around that. So we had to show what we were doing and what practices we were putting in place as a lead. So it is getting looked at, even though they don't have a defined quantitative process that they're establishing across the state for health homes to follow necessarily. They want us to have something in place and for us to dictate what we're doing to show them that we're putting things in place. So it's getting looked at.
Also, there's a question in the chat. Can you clarify by what you mean by a letter? I work with peds. I'm not sure is there a separate letter other than the 5235. So yes, you should be issuing a letter. Anybody who is disenrolling from Health Home should be issued a letter saying how to contact the CMA, how to contact the Health Home, how to re-enroll. That should always be given out to all of our members. And then also you're going to see a change come December with the notice of decision policy that we also always have to make sure that we're administering an enrollment letter. So there should always be a letter that goes with the 5234 now, and then there's always going to be a discharge letter. Whether you send the 5235 or not, that is going to be case dependent. Does anybody have any other questions? Oh, yeah, Michaela, sometimes the discharge summary and the discharge letter, sometimes those two things go hand in hand. It just, each CMA does it differently. And obviously we audit, and Hudson Headwaters is always fine. So whatever you're doing, keep doing it. Okay, you can go to the next slide. All right, another policy that pertains to our HCBS youth. So if we have members who are enrolled in HCBS and you go to complete a level of care on those guys, you always want to make sure that we're issuing the 5276. So that's that freedom of choice form within 3 to 5 days, discussing that with the family and uploading it into the record. We always have to make sure that we are having a documented conversation that we reviewed the 5276 with them. That gives them the right to choose their care management agency, their health home, their providers. And then there is a really important piece to that on that rights and choice form. So there is a form that goes with the 5276, that rights and choice form, that informs the family on how to document and how to report abuse, file a complaint. That is really important when we are audited. The Department of Health is also looking for that 5276 and a note in the record correlating to that 5276 that you have that discussion with the family. So you can upload the 5276 and the rights and choice form with the parent's signature on them, parent or guardian, or you can document in a note that you reviewed that form with them and they were informed on how to file the complaint and report abuse. That is something that we will leave individually up to the CMAs to decide their workflow, but one of those two things has to happen when it comes to rights and choice. Does anybody have any questions on the HCBS rights and choice policy? All right. Okay, moving into children updates. So on the 19th, I sent out an updated HCBS toolkit. I know that there was one care manager that was having difficulty opening that zip file. If you can't open it, please let me know. When I sent it to her separately and not in a group email, she was able to open it. But that has been updated to include the HCBS goals sample sheet. So I know we had talked a little bit about making sure that every time we're writing a plan of care that's inclusive of HCBS, we have a goal and an intervention related to that service and how that service is going to support our member. And that goal sample sheet has some examples for each service in there that you can utilize to help guide your care planning process. The core services policy has been pushed out until April 1st of 2025. That says 2024. It is 2025. So that policy has been pushed out. There is telehealth guidance out there that came out in October that states basically that this policy is in place, but there's no policy in place. So it's an extremely gray area. So if you did see that telehealth guidance policy, we're aware that it's out there. The problem with that is that NetSmart has not made the necessary changes because they were waiting on the DOH policy to drive the system changes. So right now we do have telehealth guidance out there from the state, but there's no policy in place and our system does not match that. So I know that we have been reached out to by some of our CMAs that work with multiple health homes. We are waiting until our system matches what allowances are out there. Because right now, if you did a telehealth visit in lieu of an in-person visit, you would not be able to bill, even though we have telehealth guidance saying one thing, but our system doesn't have a policy to back up that systematic change. So for right now, until further notice, please continue to deliver services as usual. We will work with NetSmart to see if those will be updated pre-policy guidance. And if so, we can issue some guidance on how to do that without the policy actually being effective. Does anybody have any questions on that? Okay. Next, we have been working with LifePlan. So LifePlan CCO is going to join us on the 18th for an OPWDD presentation. We're just going to do like a OPWDD 101 and overview. I know that there's lots of questions about getting our kiddos eligibility. We do have health home policy in place about getting our kiddos eligibility, but I know that there's still a lot of questions about that. So I reached out to LifePlan and they're going to come on and they're just going to do a quick overview. It is going to be geared towards children. So I did send it out to all of the children's supervisors, that invitation. So please feel free to forward that to your care managers. If you are an adult CMA and you would still like to sit in on that, please let me know and I can get you the invite. I did give them a list of questions that I see frequently that we have, a couple scenarios that we work with. So I did let them know that I also would like time to allow for questions. So that has gone out. Then we've had an update to our CANS trainings. It's effective 12/1. I sent an announcement out on the 5th. So for new staff, so newly hired staff, new supervisors are going to have to complete that mandatory introduction training. After you've completed your intro training, you then have 30 days now to complete your certification. Before, there was no timeline on getting that certification done. Now you have 30 days. Those self-progression trainings will still be available, but those are no longer required. Then supervisors now have 8 months to complete the supervisory training. So if once you become a supervisor, you get certified, you then have 8 months to complete your supervisory training. The live training will still be required, but does not need to be completed prior to the certification. So this is all very confusing. This will be laid out in our updated policy. But before, you had to do the live training. Then you had to do the certification. That's no longer the case. You still have to do the live training, but then you can just do the certification. The certification has to be done within 30 days of that intro training. And I did send out this morning the updated CANS schedule, training schedule that goes through February or March, I want to say. So that did go out to the supervisors this morning. You can go to the next slide. So annual certification. So for those that are already certified, the annual training is available for currently certified CANS users, and the updated annual training will be required beginning of February of 2025. So right now it is recommended. Come 2025, it will be required. And then the new thing for our existing care management staff is now you're going to be required to take that half-day virtual live training. So it's similar to when you first get your certification, you have to sit on that live training. Now every year prior to taking your annual certification, you will have to sit on that half-day live training. So that CANS schedule that I sent out this morning, that is what you're going to use periodically. I think we get it quarterly. You're going to want to plan ahead to make sure that you can attend those trainings prior to taking your certification. The children's HCBS certification is still in development. It's going to include online modules. I know we've talked about this before. It's going to be released December, January. They're not 100% sure yet. It will be recommended at first and then required. And it is still up in the air whether that certification will be an annual certification or if you will be one and done with the HCBS certification. Does anybody have any questions on the updated trainings? Okay, and like I said, updated policy will be coming out for the cans. All right, Travis, it's all yours.
All right, thanks, Jess. Appreciate it. Okay, Healthy Alliance SCN. So our lead health home has our initial credentialing phase completed, which means our application has been accepted by the SCN. So in the next 30 days, we're going to be going into the next phase of our contracting in that process. So we're just waiting to hear from Healthy Alliance on that. And so it's basically formalizing contract with them for the SCN work for a lead, as a lead with them. So more to come on that. So we're on our way to be in contract with them as an SCN lead, or as a health home, I should say, with the SCN, as them being the lead SCN. And I just got the information here for Scott Emery to reach out to him if you, as an organization, want to connect as a potential CBO if you have not already, and to get connected to them for further information to connect to their network, and also as well, just that they may be coming on our office hours from time to time for information sharing, etc. So more to come on Healthy Alliance. And then special office hours, as Jessica had mentioned and I had mentioned, we're going to hold it December 9th at 1 o'clock. I'll send that out either this afternoon or tomorrow morning to the network. It's a couple of reasons. First and foremost, the Department of Health is going to be sending out some policy updates in early December that we've got to get out to the network. Notice decision and fair hearing and transfer policy, that we've got to make sure that we get that out and get that out to the network and train on. And then we've got some other policies and procedures that we want to get out to the network. And we've got redesignation things that we've got to start to get out and updated as well, that we have on our enhanced oversight plan that we've got to start working on. So more to come on that. So we'll get that office hours out and on the books. And that is all we have today. And one more thing I wanted to mention, contracts for the Health Home Services Administrative Agreement and BAAs. That went through our final review. It's just coming out with our contracts personnel and went through our agency attorney, etc. They should be coming out in the next week to week and a half and going out to all organizations for final execution. It will be an updated agreement, so it will be needing signatures. I know we have a standing agreement where it re-ups annually because it's a standing agreement, but the fact that we're making changes to the agreement with the admin fee change, it will be signed and updated for fully executed agreement. So look for that. That'll be coming. I'll be sending it electronically in snail mail. So that'll be going out to folks. And I've already sent the memorandums electronically in snail mail. So that's happened. So just wanted to mention that again today. So be coming out shortly. And if folks have questions, please reach out as always. But other than that, I hope everybody has a great Thanksgiving. If anybody had any questions or anything they want to talk about now that we haven't touched on today before we sign off, anything anybody want to talk about? Outside of a happy Thanksgiving, gobble gobble.
Happy Thanksgiving, gobble gobble.
Okay, happy Thanksgiving, gobble gobble. Anything else? I hope you all have a great one. Enjoy.
Thanks for everything.
Take care, everybody.
Bye.